All right, so the first topic on today's agenda is the fall CFHA conference. So the call for proposals is now open, February 1st through March 15th, and the theme is breaking boundaries, redefining access and expansion in integrated care. It'll be in St. Louis, October 8th through the 10th, so a little bit earlier. So the first discussion questions are just what are your ideas for proposals? You don't have to have a fully formed idea yet. Maybe just more of a topic. Is someone interested in presenting that hasn't presented before but has a topic of interest that they could maybe collaborate with someone else on this call? And so hoping we can hear from people what they're planning on putting out there for proposals and also maybe help people make some connections. If there's similar interest areas or people who are looking for someone to work with. So
I would like to make some connections. So the groups that are out working on collaborative care pathways, pediatric, geriatric, substance use, early childhood, geriatric, and the research one. Each of those groups, which national people working on them, many CFHA members, are each going to put in a proposal. And so what I was hoping to do was let people know that, and if people are interested in that particular population, to reach out to me, and maybe I could partner because maybe you've got a good example of where you're doing that work, and that is collaborative care pathways. So if you're doing collaborative care with those populations, then reach out, and if you'd be interested in, sharing what you're doing or connecting. So putting that out there if people
I'm
are.
sorry, Verna, which populations did you say?
So this is substance use, geriatric, early childhood, pediatric, women's health. Did I say geriatric? Yeah,
Yep.
that's where we are. Yeah.
Okay. All right.
Didn't you say a research one?
There is a research, so there is a research group. We just finished a questionnaire around outcomes, like what outcomes are you tracking, what tools are you using. I was going to share it out on Basecamp, and we're collecting all of that. We have data sharing agreements, and we're going to try to put something together with like global collaborative care outcomes, like just across, not like if we can match what people are measuring for outcomes, we will. And if not, we're just going to report on what your outcomes are and then put it all in one place. So we've got some pretty big health systems working on that. We've got some smaller places. I was going to share that, but if people are interested in that, reach out to me and I'd be happy to put you on that list. Yes. Thank you, Ben.
Awesome. Thank you, Verna. What are other people thinking for ideas for proposals?
I can add at the Meadows Institute team, we will likely put in between 2 and 4 proposals. Exact
Okay.
number TBD.
Okay.
And
Do you have any ideas, kind of topic areas?
we're still working on topic areas. I think we'll do something focused on implementation. And then I think we will also try to fill in gaps of where, the SIG feels like there should be something, but maybe nobody's doing something.
Okay.
And then obviously involvement in the policy dinner.
Okay. Yeah. Awesome.
Anybody interested in anything like value-based care and connection to collaborative care?
We do have a presentation for the summit. An IPA in New York did a value-based contract with a payer that has actually gone really well. And so I was going to have them present at the summit. And if other people have something else, I'd love to combine. And Sarah, it'd be great to maybe think about what you guys have and pull that together and do a submission around that as well.
Excellent. We have two different, value-based care contracts don't going well, so maybe we could partner up.
think we haven't implemented it just yet, and I think we're considering a submission around implementing CoCM with learners. I'm in an academic institution, so using like medical residents as well as training therapists to implement CoCM.
I'd love to partner with you because Texas
Yeah,
Tech is doing that. Meadows and I are actually working on
awesome.
that jointly, and it would be wonderful to pull together. So if you reach out, maybe
Yeah,
the three of us could all come together and put in a proposal, and there's probably others. I think that's great, Patricia.
absolutely.
I'd love to work on that with you. So thank you.
Yeah, I'll definitely email you.
Perfect.
You're not gonna have any time that to present or eat there, Berna, with all these presentations.
Oh
But
no, I'm not.
Bruno is going to do like 15 presentations,
No,
one in
I'm
every
not doing
spot,
them.
like
I'm
normal.
bringing in people, and I'm the idea generator here, and then other people will do them. Yeah.
This isn't necessarily a proposal per se, but I do just want to share because I do have to log off in about 20 minutes. That thanks to the help with this group, along with CFHA consultants, Jefferson Health, which is a large university healthcare system based in PA and New Jersey, has successfully launched as of this Monday our COCM pilot and we have a standing PCBH practice, but we're very, very excited to see the outcomes. We have a lot of stakeholders very interested, as everyone can imagine, in just kind of bringing this service in addition to our PCBH to our health system. So I just wanted to say thank you. I don't know if I had the opportunity or the place or space later on in the agenda, but just a little thank you to this group.
Cool. And congratulations to you guys. It's exciting.
Yeah.
Any other thoughts? I don't know who at the Ames Center is presenting what or submitting what proposals. But we have a document of just ideas. And so one
Sarah
was,
said yesterday, early childhood. Sarah Barker did.
yeah,
Yeah.
yeah, definitely in early childhood. And there's a couple of pediatric organizations that we work with that I believe are coming to the conference this year. But I know she was going to be looking for others because I think it was more like a panel type discussion around pediatric collaborative care. So if anyone is interested, I'm happy to connect you with Sarah Barker from the Ames Center. I know one other topic was a loosely formed getting the most out of your systematic caseload review, a beginner's guide, more focused on a beginner's guide, and talking about kind of the evolution of systematic caseload review, what it looks like at the very beginning when that working relationship between the BHCM and site consultant is very fresh and new, and then how that evolves over time and what that looks like. So that was one idea. We had another idea of well, these would probably involve collaborating with Concert, and these ones listed here, but development and implementation of behavioral activation for bipolar disorder and PTSD, and talking about that experience, and then coaching and psychiatric consultant metrics. So that's also, I'm guessing, related to because it lists
That might
Verna.
be, well, yeah, that might be others, though. I think part of that may be around what percentage of the providers actually follow through with the psychiatric consultations? Like, what are some best practices? Do you track that? And then do you use that information? So, in other words, what recommendations are followed by what providers, by what psychiatric consultants? What types of recommendations so that you can fold that back into some learning. So I think Anna Ratcliffe had actually put that on there, but I think we could build it out. Like I think if others are interested in that, then we could do something jointly.
Yep, got it.
One thing that comes to mind on that is that I don't know if people agree, but SCRs often are seen by providers as just medication recommendations. I wonder if some of those SCR groups could talk about other
Yeah.
interventions and other,
Beyond MedRex.
right.
Love that. Yeah.
Yeah, I like it too.
What about sustainability? Anybody, sustainability, funding, practices, things of that nature? It's always our
I think
bugaboo,
we're
but
planning to do a lot of that at the summit, but maybe the different pro formas that are out there and how do you use them and do them? I don't know. There's 3 out there now that are kind of widely used, and one last night that just came out for FQHCs in California, which nobody wants to talk about, but it's so complicated. But yeah, I think whatever, yeah, we could totally do that for sure.
I'm not looking at the chat closely.
I just want, this is Janine Fonfera. I haven't been to this meeting in a very long time. And I just wanted to say hello to everybody. And when I saw that this was the topic for today, I, was excited to be able to pop on and just try to reconnect after kind of a 6-month hiatus of being out of my work world and kind of just stepping back in. So I just wanted to say hi to everybody. And that's why I'm listening and not talking to you.
Yeah, welcome back.
Thank you.
Hi, Janine.
Is there anyone who is wanting to present at CFHA this year but doesn't have looking for a group or another person? Christina. Any ideas, Christina, or you're pretty open?
I'm torn because I submitted one last year and it didn't get taken, which is okay, obviously. But I'm wondering if I can try to like scrub that up a little bit. But other than that, I don't really have any ideas.
Okay.
But I just really enjoy participating in that way. So
yeah. I think connecting with Sarah Barker would be good because I know she has the pediatric one in mind and she's looking for people. So that would be a good one. What was your topic that you present or proposed that you're gonna?
it was, in a sense, a sort of a lessons learned kind of a presentation on, you know what? That's a really good question. I'd have to look it up.
That's okay if you don't have it on hand. That's totally all right.
Christina, I like the one that, engaging primary care docs and referrals and, there's constant struggle for lots of folks.
We had submitted that actually for the spring conference last year, right? Or the year before. Yeah. Let's see.
An idea that I have, but not that I think our team is planning on submitting at the moment, that I would love to see somebody do or collaborate on is collaborative care in specialty medical settings. So beyond just primary care, cardiology, oncology, et cetera, et cetera.
I know someone's putting in oncology.
Great.
And CFHA has a new SIM work group that's just kicking off this month, Specialty Integrated Medicine. It's like John Dikes and Tony Mawalid that are both behaviorists that are getting together with the powerhouse of the AMA BHI Collaborative to really put some meat behind some of these specialty groups and getting some traction with having cardiologists show up and GI folks talking about integration. So very cool stuff there. I'll see if I can find that SIM work group and pop that in the chat. Okay. Great.
Thanks, Jen. All right. Any other thoughts? The theme is breaking boundaries, redefining access, and expansion in integrated care. Anything that comes to mind with that theme in particular? Oh, Julie?
Yeah, hi. So, and sorry, I just joined a little late. It's funny, I had just sent an email to Danielle and Amy at New York State. I'm in New York City. Um,
Mhm.
for those of you who are in systems that have Epic, I think you see how amazing Epic can be. And then also sometimes I think our local build of Epic, there are challenges and the decision-making bodies sometimes people aren't agreeing with different cutoffs. And so I was, we're using 10 as a cutoff for collaborative care in our primary care settings. So that's in pediatrics, yay, pediatrics, sorry, I just saw Verna's message, pediatrics and internal medicine. But for OB, because of the ACOG guidance to use five, um, we are using five, and our electronic health record is only letting us have one cutoff for everyone. So it has to be five for everyone. So we have like what the cutoff is for our best practice advisories or whatnot, or what is considered, I mean, 5 to 9 is, a risk of mild depression. But then for collaborative care, you have to have 10 or greater. So we're trying to figure out, um, okay, yeah, you think there's an Epic fix. We're trying to figure out what our Epic will actually do, I think is a different, is a different story. But we are trying to figure out like, would we be able to go down to five for collaborative care instead of 10 as the threshold? Just like when you were mentioning, redefining access and boundaries and whatnot, just sort of thinking of that across the board. And obviously we have to do, what the national standards are.
Can I just ask you, Julie, because I know, a lot of times, the 6 to 9 range, right? So sometimes I'm an 8 or a 9, and we kind of know, providers know this is going to be a 10 before long, right? So there's clinical necessities to sort of make that referral and justify it. Sometimes I could score low, like we just did a grid recently where like I could score lower on the GAD and have like another anxiety diagnosis, right? So we do anxiety NOS if you're a 6 to a 9 as a primary diagnosis and then a secondary diagnosis. And if you're 10 or above, we do GAD as a primary and then the secondary. So like that there's a place for that 6 to 9, you know, sort of bucket. And sometimes it's just some preventative and they're a month, or 2 month cases. But I definitely think there's a place for those 6 to 9 for sure.
Yeah, and I would just want to make sure that and again, I know we're talking about like the conference and we're talking about presentations. I was thinking about sort of alignment across, there's like what we think should happen, and then there's sometimes all the systems barriers. I think I keep mentioning it so you guys can tell there's a lot of systems barriers at my system. But yeah, I definitely think like we would just need to make sure that we can have a 6 or a 7 or an 8, and that would be accepted, within New York State, et cetera, regardless of the population. Yeah. Hi, Danielle.
Yeah. Hi. I saw your email, and also Amy is planning on responding to you. She actually sent me a message right before I logged into this that she was typing a response to you. But I just want to also make sure that it's clear that technically the New York State guidance is that they have to have a clinical diagnosis of depression. So it's not really score dependent if they meet the criteria for a diagnosis. Yeah, I see Verna just put that in the chat too. So, I would say, like, to your point, it's more exception, not the rule, that you have the scores that are below 10, but they certainly wouldn't be excluded from enrollment by our standards for collaborative care if they met the diagnostic criteria.
Okay, that's great. Even if it's an NOS, like you're saying. Okay.
Yeah, yeah.
Perfect. Thank you. I was not aware of that.
And
Thank you.
we're not seeing payers deny the NOSs across collaborative care. Like, sometimes there's been a history of that. We don't actually see that. I think you would want your clinicians to clarify it. Like some people are NOS, right? You'd want people to clarify it if that's provisional. But yeah.
I'll
Thanks.
just add another group, UW Health in Wisconsin, that also goes by the diagnosis and not the strict cutoff, even though we recommend 10. Because another thing, as many people here know, there's underreporters too, right?
especially in pediatrics.
Yeah.
I was gonna say, especially people with anxiety who don't want to appear incompetent.
Julie, you brought up a very good topic of
Mhm.
system barriers. That sounds like a great presentation.
It does.
I think you got a full house on that one.
Any other presentation ideas
I think Julie could write a book on that.
on systemic barriers to implementing collaborative care? Yeah.
New York Presbyterian. Amazing things. That's the motto. Amazing things.
All right, well, I'm gonna move us along, but you heard from your colleagues and connect with each other on topics that you want to collaborate on, and let's get those submitted. So one update that I had was just thinking through creating a collaborative care SIG directory. So just wanted to put out there what I was thinking of for survey fields. And then the idea is we're going to see if CFHA will distribute the survey on our behalf, but it would be a much quicker and easier way to gather the information. So obviously name, contact information, state, organization. And then the areas I was looking for feedback was, well, if there's anything just basic demographic wise that we should ask, but the type of organization, if there's any I'm missing there, and then also areas of expertise. So types of organization I included so this would be kind of a drop down menu, and areas of expertise would probably also be a drop down menu, with specialty being a sub drop down that probably could have like a multi-select option. I think any of the areas of expertise should have a multi-select option, but for type of organization, FQHC, RHC, primary care practice, household-based clinic, telehealth provider, behavioral health organization, and a CoCM vendor. What other organizations am I missing?
In the chat, we had academic environments.
Yeah. Okay, great. Thank you.
And then also Christina put in maybe also areas of interest.
Oh, okay. I like that. All right. Any thing you can see that I'm missing for areas of expertise?
EHR use, share best practices, cardiology. Well, we got a lot coming in. AI, use of AI, and then suicide care and CoCM.
And then what electronic health record?
And the goal is that this will be a, contact organization, a directory. So if you have a question looking for a specific place, then, or expertise, and then we can kind of support each other beyond just this, this meeting. And Christina put in research as well in the chat.
Great, thank you. Fast forward to then we had one other discussion for today. I don't know do one of you guys want to start us off? I'm gonna move my dog out of this room. Please bark.
Ashley, you want to jump in?
Yeah. Hi, everyone. So we had thought of this additional topic around key performance indicators for collaborative care. I know when I was expanding my program, it was something we really had to dig down deep and make sure we were in alignment with our organization's existing KPIs that would help really resonate with our executive leaders with the work we're doing. And so we were curious, certainly there's a lot of us on here who are at varying different touch points on the CoCM continuum of, being in the field for 30 years, being in the field for maybe 2 years, and different points in your implementation. And I think it's helpful for us all to talk through, any lessons learned from those of us who have, developed KPIs and who we've developed them with, and specifically around fidelity of the model, financial sustainability, equity, is a big one over in Hartford Healthcare we've focused on, and certainly quality improvement. And so, just to get us started off, I'm curious, has anyone have any lesson learned or key pearls, around key performance indicators that they want to share, or anything come to mind, just seeing that on the screen and saying, oh yeah, like we're trying to figure that out right now.
Yeah, I can
Right.
share for part of our oh, sorry, Ben.
No, go ahead.
For
Go
part of
ahead.
our SAMHSA PIPIC grant, we are trying to dive into some of the equity data, um, and really just putting it out there that we're finding, we work with many organizations and different health records and different registries, and we're just finding how differently this is tracked across different systems and how difficult it is to define and then collect it so that we could do anything with it. So that's just something we're working through, but I would be curious if anyone else has thoughts on that.
Danielle. Their thoughts? See.
I can chime in from maybe a rural perspective. I
Yeah.
worked in Montana for Healthcare Foundation that provides training and TA to a number of primary care practices across the state, several of which are trying to implement collaborative care in different forms and with different capacity and resources. And so we've focused a lot less on the clinical outcomes data, because we sort of reiterate that if you implement the model, the outcomes will follow. And so we try to lower the barrier for the data reporting of like patient specific outcomes. And we really focus on, I don't know if somebody can go back to the previous slide, but some of those metrics like, number of patients on the caseload per FTE of behavioral health care manager, percent of patients being engaged in that, episode of care, that month of service, and some of the performance metrics as opposed to clinical outcomes. Just thought I'd share that if it's of interest. And that's been beneficial because it really helps us hone in on the behavior, the team members' behavior, as opposed to like the data that can be very frustrating for folks to try to gather and extract from various systems.
I would just like to add to Liz, what you just said is that if you start with those data points, which are very clear data points, then from there you can extract more, right, of the other improvements, of the other health improvements. So out of this group of patients, and then from there you can extract further. But I agree with you. You need all of those, really the financials, the what's going to keep it running and not what's going to make it be for every dollar we invest as a health system, we're going to get $7.50 in return. So it's always proving that that's where we always have to go back to that point, I think, just to say.
It just made me think of, we started similarly with really, metrics of performance, like percentage of patients referred compared to percentage of patients who were actually scheduled and had a completed visit. That was a big one. And I gotta say, we were at like 40% initially, and I was like, oh no, I'm gonna pull my hair out, but it's okay, because then at least really what you want to work to. And sort of, yeah, I agree, Liz. I think you mentioned like, caseload, average enrollment length is something, we do as well.
Mm-hmm. I think a big one is that conversion rate, the number of referrals, the number that get converted into care, right? The percentage, and then the percentage that go to a second month. So the percentage that have a billable first month, and then the percentage that have a billable second month. I think is really important, particularly when you're implementing. I don't love the warm handoff because I think that actually warm handoffs are overrated. And I think people feel like they have to fill collaborative care on warm handoffs. And I think that leaves a lot of underutilization, and it's more about population health and putting you know things in place that are systemic, right? That everybody who scores over 10, everybody, that it's more of a pop health focus than sort of just the warm handoffs. So thinking about what that looks like.
I agree with that. And if you're not doing warm handoffs, how is the provider introducing collaborative care, getting consent, and making it easy for the BHCM to say, hey, Dr. Smith told you I was going to call. Here I am, right? How do you tee up the program so the BHCM can engage quickly?
Yeah, we do watch the percent of patients who get specialty referrals because we find out sometimes people don't really understand collaborative care, and the site consultants or the care managers will send, generally it's only like 2% of the people that actually get referred to an alternate level of care, but we watch it just to see, like you'll see it be higher across certain care managers or site consultants.
I agree, Bernard. That's been interesting for us to look at that percentage referred out.
Yeah.
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 Oh, and Michael, you wrote, yeah, the lecture at the October conference supports that view on from handoffs.
Yeah. I think it sets people up for, I don't want to say failure, but I get calls all over the country from people who say, we started collaborative care and we're not getting that, many handoffs. And like, it's just not, like I always say two pop health, things. So yeah.
Yeah, with that, Verna, we were just kind of having this conversation yesterday with someone, but I'm noticing that just the universal screen rate isn't here necessarily, and that's something that always leads to those fundamentals and like fidelity conversations, and then also gives them some numbers to think about as far as referrals, and then what else is happening to those patients that are scoring positive if they're looking at their positive yields. That's something we've been using as a tool in coaching.
I tend to think about this as process versus outcome measures, where outcomes really are the clinical outcome measures. And I think some groups struggle with this because when you're first starting implementing collaborative care, you're not going to have clinical outcome measures for several months. So you're going to have to rely on these process measures like universal screening, yield rates, is systematic case review happening weekly? How many patients are being reviewed during systematic case review, and on and on and on. So I think you need to focus on process measures in the beginning, and then you need a plan to have an additional strong focus on truly looking at patient outcome measures when you hit 5 or 6 months, when you have patients that are finishing the program and hopefully graduating, with scores in remission.
I was curious too, Annie, Ben and I had talked about in developing KPIs, the importance of clinicians, the clinical lens involvement in that. I'm curious to hear from folks, in your organizations, like who's been involved with developing those, and have you, leveraged your existing team? And Ben, Annie, certainly feel free to jump in with other thoughts around what we were thinking through.
Personally, I think having a clinician or someone who's doing the PhD in those discussions is super important, because when KPIs are developed from maybe finance and then drop down on folks with the clinical world, they don't have an understanding of how it works. I've heard folks track no-shows and cancellations, and oftentimes, clinicians are not, don't have much effect on those, but then that does affect the bottom line. This is just one example. So that's what I was thinking.
Okay. I would just wonder too, if, like when you're working within a health system and when So when this is implemented with fidelity to the model in a health system, then you can measure all sorts of, as someone, has someone's A1C improved, has someone's, the other part of the body that we know the mind affects, right? So that's really important. So I don't know how many folks, are working in healthcare systems versus mental health clinics, because I think if you're in a mental health clinic, it makes it much more difficult to be measuring, those other things that we measure. You still could measure, has our clientele, has our patient panel had their mammogram? Have they had their annual wellness visit, et cetera? So you can still do it out of a mental health clinic. And certainly if you did reverse collaboration where you had a provider, a PCP in your mental health clinic, you could do it that way too. So sky's the limit.
Yeah.
You're the right foundation.
That's a good point about right type of organization. And I think we've tried to talk more about like reduction of ED utilization and tracking that. That's been a moving target. I'm curious, other folks, regardless of, what location you're in, type of location, have you had C-suite specifically ask you around, access? That's something that's come up for us a lot.
Verna, can I call you out a little bit on what you were talking about as far as conversion? You talked about, referral to, the first appointment or first billing month, something similar to that, right?
Yeah, I mean, I don't use the word appointment because that sort of,
Yeah, sorry.
most of this, so it's like a contact, right?
Yeah, contact, right.
And so the number of referrals, so if I get 100 referrals, right, just because easy math and I'm tired, right? And then 75 of them convert to have a billable episode, right? So it's some amount of time that is then billable for month one. How many did I convert, right? What percentage converted to be like an active patient, right?
Mhm.
And then what percentage of those went on to have a second billable month? Because that's where, particularly like Sarah was saying, that's such an important process measure in implementation. Because if you're not converting the referrals, then are you not calling them timely enough? Is your script not right? Are you,
Right.
not getting them, like whatever? And then what's happening during those first conversations or those initial contacts that are carrying us over to the second. And we know in month one, it's the number of contacts, not the amount of time, that's most closely tied to engagement and outcomes, right? So if I have 4 or 5 contacts in the first week, the second week, I'm more likely to carry someone over to month 2. But then you can go back and train the care managers. Hey, how could you have more contacts? How could you set smaller goals? We had a big conversation, Danielle can attest, on the New York State call today about whether or not you tell someone about collaborative care. I am in the very anti do not explain collaborative care camp. Not necessarily a discussion for here, but we did have a fairly, we couldn't even get to everything on our webinar today because we sort of got derailed on that discussion. But like what's happening in those first couple of contacts that, will help carry me over. And you can do a lot of course correcting there. So Sarah, I don't know if you want to add to that, but like those process measures.
And that also then leads to how we train the doctors to present it and get consent as well. And that's always a difficult,
Yeah, I work with Verna. She's part of my team. She helps me care for my patients who are anxious, like we talked about today. I'm gonna have her give you a call later. She's pretty funny. I think you're gonna like her, like there you go. Like I just teach them, that and then stop talking.
Yeah, we've done a lot of scripting for just like that for the providers.
Yeah.
And like I'll pop quiz them when I'm rounding, like, oh, how are you introducing it now? did it change from 3 months ago? We also have done a lot of work around the nurses too, because in the nurse visits, oftentimes these things will come up and the nurses feel a lot more confident with some scripting too.
Yeah.
One of the
And
things
also
that
getting, oh, go ahead, Sarah. Sorry.
Oh, I was going to say following on what Verna said, one of the things that's hard for folks who are used to working in like traditional outpatient psychotherapy or systems that are trying to make collaborative care look more like that rather than have it look the way that it looks, the way that it is this idea that appointments should be the same lengths. No, they shouldn't.
Right.
You don't have to have all your contacts be 30 minutes. It can be 5 minutes, it can be 10 minutes, it can be 15 minutes. It's going to vary based on what's happening, right? Is it a short call to ask the patient, were you able to fill your prescription? Have you started taking it yet? And then another call, couple of days later, hey, are you noticing any side effects? You have dry mouth, you have, XYZ, kind of go through the list of potential side effects. So when you see systems that have templates built out where all of the initial assessments are 60 or 75 minutes and all of the appointments are 30 or 45 minutes in length, it makes me think that they're doing more psychotherapy-like services and not allowing the BHCM the flexibility to truly deliver collaborative care how it's supposed to be delivered.
Yeah, that is such a quick way to know whether or not an organization is doing collaborative care. If everybody's schedule looks the same, that's all you need to know.
Yeah, I just want to say though, I think to follow up on that, that collaborative care management, like which everyone here knows on this call, obviously, but very oftentimes, and especially just having to keep the lights on, pay the bills, schedules do have to get filled throughout the day. And very often that's why you would have someone who's licensed who can see patients for psychotherapy if you needed. But regardless, then you have your bachelor's level. Back in the day, like through Intermountain and such, they used to call that the behavioral health clinician and the was that true? Behavioral health. I don't remember that one. But anyway, it was built into the model that there was always an assistant. And so that translates into behavioral health care managers, so to speak. Doesn't mean they have to be in the office. They can be out of the office. That part doesn't matter. But I'm just saying that to have the clinician have that direct contact with the psychiatrist, with the PCP, with the patient, and have it really do the best of the best, do fidelity to the model where you're going to get your greatest outcomes is what we should always be shooting for. I just think, because that's how I was raised in the world of this.
I think we don't see that being successful nationally, that split model. Like, I think if you were going to ask people who do implementations, they would say we wouldn't recommend that. And for the most part, the pro formas that we have, you have a behavioral health care manager who is most of the time a licensed provider, but it can vary, but that the pro forma will allow that person to be self-sustaining or that service line to be self-sustaining, particularly if the state has, the codes and the fee schedule, which actually 36 of them do now. And the pro formas that we have will allow you to put in your care manager salary, fringe, and overhead, your payer mix, and then know at what point you're going to be self-sustaining so that like usually it's like 60 to 62 patients, they're self-sustaining.
Yeah.
And then you're revenue producing with the average caseload.
Sure. Actually, both, I would say, like, because we were our program originally was implemented with, oh gosh, I don't remember the name of that doctor, but in any case, having a licensed professional available as well is really terrific when you're able to do so. And our research would show, and our outcomes would show that is the case. So I'm just saying both and can work. It looks like yours are working extraordinarily well as well. I'm just saying that kind of those of us who kind of trudge through the making the model way back when, we say both and working. I think that that's like where Ashley Shattuck works in that organization, and that was Maine Behavioral Health and others that have kind of been able to make those models work. There's a lot of organizations that make the model work. Intermountain, Montefiore. So yeah, it doesn't have to be either or. It can be both and. That would be the more help, the better.
I guess I'll add that at the like system level, absolutely both and. One model doesn't work for every patient and you need different access points. I think it's particularly hard for one person working as a BHCM to have half their time spent in psychotherapy or other activities. That it makes scheduling really difficult, and it's hard to switch back and forth between providing a psychotherapy model, kind of 60-minute appointments, and then switch to my brain to saying, I need to do something in 10 minutes here.
Yeah.
Oh, yes,
Yeah.
absolutely.
And
absolutely.
There are some states that do require the care managers to be licensed.
Yeah. Okay. Well, you can make it work financially, even if they're licensed. There's
absolutely, without a doubt.
Absolutely.
Yeah, most people do. Yeah.
Yeah.
I can put in a plug here. Coming soon, the Meadows Institute is going to release a summary of BHCM requirements across different states. Some of that information has been very difficult to find. So there's some caveats, right? It's the best of our knowledge. If you know something different when it comes out, please let us know so we can update it. But we'll share that out to the SIG once that is released.
That's great, Sarah. And as we wind down, I'm curious, if you were to give, a KPI Pearl to share with someone who is in the process of developing them, what advice would you give? What would you recommend? Where do they start? Whether it's with easy data to access. I'm curious.
I would say, I think it is important to think about what would you like to set as a KPI if accessing data wasn't an issue, so you can have some ideas and goals to work for that are goals that are more long term. But I also think it's important to really have some accessible data. So if it's something that's easier to harvest the information to get the data so you can evaluate it sooner than later. So measure something that you have a way to get the information, but then don't let that limit you for all of your metrics. I think you should still try to work within the systems and within the EHRs and figure out how to also get some of the other really important pieces. But yeah, and then I also think about figuring out what was the why for your organization implementing collaborative care, and how is implementing collaborative care hopefully going to meet that, and how can you measure that? Because I think that looks different across a lot of organizations. For others, pearls.
And what are the other people in your organization working on? So how can you partner with them as a team member and say, how can I help you with your patient need, and how can they help us?
So that relates to, I've been seeing primary care docs have bonuses for, is this what you're talking about? It's like bonuses for measuring BMI or something like that. So you're talking about aligning CoCM goals with primary care metrics?
Yeah, I mean, I'm not sure if it's even how many bonuses per se, or if it's just people being able to keep their jobs at this point. I'm just, I don't know. I mean, I'd love to say that PCPs are getting certain bonuses for, it's so hard to actually get a paycheck after that initial, it sounds really good on paper, but by the time everybody pulls away what they pull away, it's actually very small for the PCP, but it is a goal in front of them, certainly. Yeah. But sure, I mean, yeah, we all have those. Well, a big one, that's why I think what you're all saying, Ashley is saying, it's that ED utilization. I think that PCPs get hit on for that's a big hit for them
We
because
do.
it's so expensive. And our folks are the highest utilizers of the emergency department or of all medical services. It's, our people. But
Do you pull that across your collaborative care services? Because a lot of the recent total cost of care data has shown the ER utilization has gone down. Like several of the blue plans in multiple states, some of the IPAs are all showing it with collaborative care, like that total,
awesome.
but the ER reduction, which has been pretty
Good.
cool.
That's awesome. Yep. Great. Yep.
Yeah, we have really good data on that now.
Good. Good. Love it.
Well, another thought-provoking conversation. Thank you very much. Unless there's any other comments. Very interesting.
Well, keep up the good work, everybody.
Nice to see you all.
Have a good rest of your day. Thank you.
You too. Agree, Michael. Take care, everyone.